Thank you, Fatima. Can you hear me? Yeah. Good morning, everyone. And really, it's terrific to be here. And as I present these data, please keep in mind what Kirti just presented, the real options for therapy for kids with long-acting newer agents. And you'll see what we're trying to accomplish in terms of HIV remission and cure with very archaic regimens is a very high bar. And so I'm going to start. I have served on the scientific advisory board once for Merck and company surrounding ARVs for neonates. And so I don't need to tell the group these numbers, and you heard the updated numbers today, but just kind of think back in 2012 when we were trying to come up with a scientific rationale. Why embark on an HIV, and it was called a cure agenda at that time because we were aiming for cure, and then realized that we need to think about an intermediate stage in terms of remission before you can declare someone as cured. But this actually started within the IMPACT network under the leadership of Elaine Abrams in the Treatment Scientific Committee, where we had to kind of think through a framework for HIV remission and cure. And it had to do with the numbers, that despite the notion in the adult space that pediatric HIV infection is disappearing, the numbers remain, and as you heard today, 160,000 new infections with the similar number of 1.7 million, and this is likely to increase with COVID. And secondly, we had to sort of say, okay, why think about this? And art is life-saving, and we all know that. But you heard the numbers again. I think it's very important to think about the numbers that Kirti just mentioned. 56% of kids are suppressed, and only 6% have long-term suppression. So those are good numbers in terms of, actually, I was thinking we try to come up with endpoints for our clinical trials, and how do we think about those endpoints? And if we use that benchmark number, and I'd love a reference for that, of 6%, we don't need to go very far to think about a remission agenda. But we know that ART is life-saving but not curative. We have adolescents now, actually young adults, 20 years of early antiretroviral treatment. From infancy, completely suppressed, HIV seronegative. Some go off therapy and rebound within the same 2 to 4 week time frame. So 20 years of antiretroviral treatment, insufficient to eradicate reservoirs. Virologic failure is high, and so we need to have a new therapeutic goal for HIV therapeutics in children, including considerations for stigma. And so I kind of want to bring you back to visually think about what we're thinking about in terms of HIV remission and cure. And the first place we're starting is with the best characterized reservoir for HIV, shown in blue, quiescent CD4, resting memory CD4, resting CD4 T cells, carrying HIV in integrated form, intact proviruses within the epigenetic landscape that it can be reactivated. And the arrows showing the yellow symbols is to remind us, we always think of this reservoir as very quiescent, and it is quiescent, and it's able to return to quiescence. But if you look at any given time point using low-level viremia assays, in adults up to 7 years and in kids up to 7 years, you can detect trace levels of HIV viremia. Now, those studies haven't gone out to 20 years of treatment, and I think it's important to think about that. But these reservoirs are reactivated on a daily basis, and it suggests why patients when they go off treatment, these cells are primed to produce virus to infect susceptible target cells and fuel viremia. And so the major strategies to try to eliminate the latent reservoir in resting memory CD4 T cells. There are probably other reservoirs that haven't been studied, particularly within the central nervous system, really because of accessibility of being able to sample the CNS. And I urge you to stop by the poster being presented by Anne Schrudy and Thor Wagner from IMPACT 2015, which is the first study to actually systematically look at the CSF in young adults living with perinatal HIV and suppressed for up to 18 years. The data are under embargo, so we can't present it. And so I'm going to give an update, and Lynn and Elaine asked me to give an update on the clinical trials roadmap for HIV remission and cure. And so we had to kind of think about, in terms of remission and cure, what are the key features of perinatal infection that can drive us to identification of remission and cure. And you'll see the trials are skewed towards very early treatment within 48 hours of life, and some of the studies up to 7 days of age, and then early therapy, 2 to 3 months of age. We still have a lot way to go in terms of clinical trials in later childhood and adolescence. There is a study within the EPICAL consortium in adolescence of a therapeutic HIV vaccine, DNA vaccine, which I think has enrolled, and it will be interesting to see those data of early treated adolescents treated from early infancy. And then with respect to late childhood, Impact 2039 is a protocol being led by Mark Cotton and Avi Violari, looking at therapeutic vaccines in combination with broadly neutralizing antibodies to achieve cure. And so actually to go back, the unique aspects that we focused on in this first phase of trials is really, we know generally when kids are exposed to HIV. You heard today, though, there are a lot of undiagnosed infection in women, which has allowed us to begin an agenda of very early treatment in infants. And the immune environment is different, and it's really because the cells are mostly naive. The reservoir resides primarily in memory CD4 T cells. There are emerging data in adults, and we have data in pediatric patients that naive T cells do harbor intact HIV proviruses. The mechanism by which naive T cells are being infected is unclear, because the model by which this reservoir is proposed to be established, and I think all of the data to date in the past 20 years support this model, is that the memory CD4 T cells become infected when they're becoming effector memory T cells, so in the presence of being stimulated in response to an antigen. But there's some mechanisms by which these effector cells are able to escape viral cytopathic effects, immune effector mechanisms, and probably have pro-survival mechanisms turned on that allow them to transition to arresting memory CD4 T cells. Now, this is a busy slide, but it was really important to really compact work, 20 years of work from many groups across the world, studying HIV reservoirs in children, specifically focused on early treatment of perinatal infection. And we do know now from several groups, including our own, that the reservoirs do become smaller in children. So when we think about early treatment, it's important to think about early treatment. Kids are starting out with similar proviral loads as HIV-infected adults. But what happens is over the time course of life and prolonged suppression, meaning getting to later childhood, around 7 to 8 years of age, and through adolescence, the reservoirs do become small. And when I say small, when you look at just HIV DNA, of which 90% are defective, on average, some of these well-suppressed adolescents have less than 5 copies per million PBMCs of DNA, of which 90% are not intact and therefore not replication competent. The reservoir is low diversity, meaning it's often very clonal. And so that's a great viral landscape to think about immunotherapeutics, where immune escape mechanisms are not at play as much. And the low diversity and low activity of the reservoirs with early treatment is really supported by biomarker data done by the SHARE trial and the EPICAL group and our group, really showing that these long-term suppressed kids have absent HIV-specific immune responses. Many sometimes test HIV antibody negative, allowing parents and adoptive parents to actually question whether these kids are infected. Using the most sensitive assays, it's actually very difficult to detect infection, but we know when they go off therapy, they rebound within 2 to 4 weeks. Importantly, we recently recognized that latent reservoir is more difficult to reactivate to produce virus in adolescents treated from early infancy. And this is actually a critical finding, because one of the major strategies for purging reservoirs in the adult space that's been studied the most is actually latency reversing agents or innate immune enhancing agents. So we need to understand the mechanisms by which this is occurring, whether it's an epigenetic effect, the intrinsic properties of the cells that carry infectious proviruses, or a combination. But I hope I convinced you today that we're in a space where we knew with early treatment there are unique outcomes of long-term infection with HIV. And then on the backdrop of developing that agenda in 2012 to 2013, we discovered the case of the Mississippi baby who had received very early treatment, really treatment as part of prophylaxis with AZT3TC and nevirapine within 30 hours of birth that led to this state of 27 months of remission. And I don't need to go into detail, but just to say is that this is a case where during remission, there was complete viral quiescence. There was no HIV-specific immune responses detected, no low-level viremia, no replication-competent reservoirs, and yet there was viremic rebound. And I think this case definitively proved the very, very early establishment of latent reservoirs in the course of HIV infection, and that was the lesson learned from this case. So with respect to our landscape, and I go very quickly, and I want you to look at the regimen. So there were 4 studies looking at early treatment, very early treatment of infants towards remission to replicate the Mississippi baby. And if you see the intervention we're looking at, it's really not terrific. It's AZT3TC nevirapine with lopinavir ritonavir. So I'm hoping with all the regimens discussed today by Martina and Kirti that we're going to get to a better space with HIV remission and control in children. And just to add, on version 2 of P1115, the therapeutic that's being studied is raltegravir, with a plan in version 3 to transition to dolutegravir to kind of align with the treatment landscape that's rolling out globally. And this is the first study that will look at very early treatment of neonates in combination with broadly neutralizing antibodies. Impact 2008 will be presented at AIDS, and again, this is under embargo. It's primary therapy with and without VRC01 and looking at its effects on infected cell concentrations. And then the Tutelo study, a landmark study by Roger Shapiro in Botswana, looking at treatment switch to combination BNABs. P1107, I must say we opened this trial, and this is spearheaded by Yvonne Bryson, looking at cord blood transplantation with CCR5 delta 32 cells. We did not identify a child to receive this procedure, but did report, Yvonne reported this year on the New York woman who achieved remission and possible cure with this, and then the hurricane trial by the EPICAL and Penta group. And so I just kind of want to highlight with respect to HIV cure agenda, this is not an agenda that's focused on resource-rich settings. This is an agenda that's focused on where the pandemic or the epidemic lies with presence in 12 countries and 38 sites. So I'm going to quickly go through what we presented at CROI this year on Impact P1115, the goal to replicate the Mississippi baby, but just to say there were 2 cohorts, cohort 1, which is a prospective cohort of high-risk infants, and so again, we had to have an ethical conversation around giving infants who are likely not to be infected with HIV a regimen that hadn't been studied. So there were 440 high-risk infants whose moms did not know they were infected, of whom 36 were identified as infected and 34 went on to study treatment. So that means starting therapy within 48 hours of life and then continuing onwards. And then cohort 2 was a convenient cohort to try to see was there a window of opportunity beyond that 48 hours. And so these infants were enrolled within 10 days of age but had to have received 3-drug ARV. On the left, again, I want to point out the data I'm going to present in terms of virologic suppression and potential remission is on nevirapine and lopinavir-based regimen, but version 2 and version 3 hopefully will look a lot better, including version 4. Again, these infants were mostly from sub-Saharan Africa, with 30% of the infants in cohort 2 from North and South America. I'm going to go very quickly, but some key features on this slide, and I think what I want to highlight is these are very labor-intensive studies. So when you hear the numbers of 460 mother-infant pairs in sub-Saharan Africa, trying to enroll and engage participants and mothers who didn't know they're infected in the first 48 hours of life. This is really remarkable and attests to the women who are really engaged in moving the needle towards prevention and treatment of HIV infection. You can see the differences in time of antiretroviral treatment, 7.3 hours, the first ARV in cohort 1, and 33 hours in cohort 2. Now, if you look at the viral loads, you can see kids are born with pretty high viral loads with in utero infection. So these are all in utero infected infants, 4.9 in cohort 1 and 4.1, and a lot of infected cells present, 2.4 logs and 2.8 logs at start of therapy. I highlight this slide to show the really intensity of the study, multiple HIV RNA testing, HIV DNA testing, and antibody testing, to be able to identify some biomarker profile to guide us towards who would be considered for ART interruption. That's, again, a tall order, ART interruption to detect remission, because there's currently no biomarker that's predictive of remission when you're on antiretroviral treatment. So it requires treatment interruption. And so we actually, in developing this trial, had to come up with very strict criteria for who would stay on study and remain eligible for remission. And just to point out that the infants had to maintain potent suppression of virus replication after 48 weeks of age with absolutely no target detected, and to be evaluated for remission had to test antibody negative, had no detectable DNA, and normal CD4%. And I'm going to go very quickly. The main part to stay on this study is you had to maintain virologic suppression. And these are not terrible suppression numbers when you think about the regimen. At week 24 of treatment, 75% in cohort 1 and 88% in cohort 2, maintaining virologic suppression. HIV DNA load decreased similarly as we would see with early treatment. So we didn't see a faster decline in HIV DNA, about 1 log per group, with 19% in cohort 1 and 22% testing non-detectable by 24 weeks of treatment. This is an important benchmark. So around 2 years of age is when we thought we would begin to start ATI assessment. And you can see there's a large fallout in terms of maintaining strict virologic control, with 33% in cohort 1 and 57% in cohort 2. And I'm not going to say only, because I'm going to say we have 33% and 57% to be optimistic about these findings. And just to kind of point out, if you look over time in those who maintain suppression, 64% got to non-detectable DNA and 71% in cohort 2. And I do have to go very quickly, but just to point out, in red are 4 infants who had no detectable DNA throughout the study. Just to point out, with respect to the biomarker profile, in the end, at 2 years of age, 19% met all criteria to be eligible for ATI, and this part of the study is currently ongoing, obviously much later. The goal here is to identify, we just was hoping to identify 1 case of remission in this, and hopefully we identify this in addition to the cases discussed here. I want to come back to other clinical trials looking at very early treatment. In the Leopard trial, which Elaine Abrams is part of, led by Louise Kuhn. Again, their primary entry criteria for ATI had to do with being suppressed and having normal CD4 percentages. And the main point of this study is very few infants actually met the study criterion, so ATI was deemed not feasible for this study. The Botswana early infants trial study showing that with very early treatment, there were very small reservoirs, as shown by the box plot, by 2 years of age, and a landscape that was largely driven, shown in green, by defective proviruses, and in red, intact proviruses. A study by Philip Goulder's group, which is an observational cohort study of very early treatment of in utero infections, I think about 191 infants, just kind of emphasizing the scale up of this application of very early treatment, to get to Martina's point about think about enhanced prophylaxis and very early treatment strategies, and confirming infants are indeed infected. So I hope what I can tell you at this point is that low reservoir size is achievable. We've learned from all of these studies by 2 years of age at very early ART, potentially enabling ART-free remission, and this is being evaluated still with ART interruption in P1115. These therapies are really advancing knowledge on HIV reservoirs, biomarker profiling, and remission potential that I'm really hoping the newer micropatches and long-acting will change our landscape in responses, with important safety, dosing, implementation, and management of newer therapeutics and newer treatment goals. I want to end with the study, the Totelo study on adjunctive therapy with broadly neutralizing antibodies, a new area of therapeutics, immunotherapeutics, antivirals, but potentially have immune-enhancing effects. And shown in blue are actually the BNABs, or BNABs that have entered clinical trials in infants and children, which is pretty remarkable that we've been able to keep up with the pace and investment in these studies, and done in the Impact Network and also by the Botswana group. And so this is the data from the study presented by Roger Shapiro looking at infants in the early treatment study and to see whether treatment switch with combination BNAB would afford virologic suppression for up to 24 weeks. And in this study, the infants received 2 monthly infusions, VRC01 and LS and 10-1074 intravenously. And the study was broken up into 3 parts. And what you should pay attention to is step 3. So the infants got broadly neutralizing antibodies, 25 of those, and then they were taken off ART and monitored very closely for viral rebound, defined as viral load greater than 400 copies per ml. And overall, and I don't have the details, it was safe and well tolerated with expected pre-dose troughs. But what was critical here in the finding is 44% of the infants maintained virologic suppression for the 24 weeks period, and 56% had rebound but resuppressed on therapy. And so the overall study findings were that 44% exceeded the thresholds of success of 30%, and they identified a few markers that were correlates of success. Those with longest continuous virus suppression and lower proviral DNA load at birth. And importantly, all children resuppressed. So I think altogether this study highlights that perhaps very early therapy combining with immunotherapeutics and BNABs may provide sustained virologic suppression. And so in summary, I hope I've convinced you that there have been substantial advances in the investment, development, and implementation of HIV cure trials for infants and children. We have much more work to do in the older age group, but that there is potential for ART-free remission with very early ART and BNABs or immunotherapeutics. I think this is very promising. And the progress to date really provides the framework, the field framework, the staff framework, the clinical trials framework, and the scientific rationale for continued investment in building on this portfolio and program. A small part of what we have to do as a pediatric HIV community, given the astounding numbers you heard today from Mary and Martina. But I'm very hopeful about these studies. And just a pitch for Impact 2008 that's going to be presented by Alka Ketan as a late breaker, and several studies being presented at the meeting on pediatric viral reservoirs, including from the Thai cohort study, which will be very interesting, looking at inducibility of the reservoir and the proviral landscape, really I'm hoping confirming our findings in the US of paucity of intact proviruses through prolonged suppression of virus replication and lower inducibility of the reservoirs, which may need us to think about more block and lock strategies rather than reactivation strategies around the development. And work by the EPICAL Consortium on CD4 and viral load trajectories over 2 years. We really need to understand these trajectories. Now, I have a number of acknowledgement slides, probably as many as my talk, because it's going to take many, many villages to do this. But first, to Roger Shapiro for spearheading the early infant trials group and also the Totelo study, and for sharing his slides for me to bring to you today in his study team. Obviously, the P1115 team that was version 1 was co-led by Yvonne Bryson and Ellen Chadwick, and now version 2 by Ellen Chadwick and Jennifer Zhao. Really, that this is a team effort. It's no specific individuals bringing this, the acknowledgement for impact and its funding, or impact leadership for really supporting these cutting-edge studies that we're trying to fund in a framework of limited funds and a lot of work to do in the treatment space, the HIV Cure Committee, and the new established, and obviously the people in my lab who do all of these DNA testing and latency reversing studies to give us a framework to think about HIV cure strategies and efficacy of our interventions. And I want to end with really the Pave Martin Delaney Collaboratory. That was it's a consortium of investigators, not all, but as many as the pediatric investigators working in this space, and we hope to build out this program supported by NIAID, NICHD, NIMH, and NIDA to really look at in vitro systems, animal model systems, towards HIV remission and cure. And thank you.
Thank Thank you so much, Dr. Persaud. So we have time, we have 10 minutes for questions before we go to break. And I'll invite the folks in the room to come up if you have questions. And we'll invite the folks online as well. I might not be seeing your questions, so we'll just double check that that's working well. In the meantime, before we get started, I had a question for Dr. Persaud. Just clinically, I think we all have these anecdotes of early treated children who've come off their treatment just because they stopped, and they seem to be in remission, or post-treatment controllers. You know, they have viral loads that are undetectable for a few months, sometimes a few years before they admit that they weren't taking their ARVs. And I'm wondering, in the studies where people have fallen off protocol, who have stopped, what is the median duration before they rebound, or is there evidence of these post-treatment controllers among the early treated children?
So I think you should report that if you found early treated adolescents who've gone longer. I know we've had one adolescent who went for 24 weeks, but in reviewing the history, it looks as if that child had reached virologic set point very early in the first few months of life. So may have some natural factors, and also I think it was HLA-B27 positive. So may have some other factors leading to post-treatment control. But it would be great, and maybe we should think about some way to think about collecting these cases and describing them, and then some detailed assessment to understand why there's such a post-treatment control state, if there is in pediatrics, because the ones we know about, and I don't think any more, and please speak up if you know of any cases, is really the Mississippi baby who's not, was really more remission with no detectable virus, and then the French adolescent and the South African boy who will be presented again, I think at the IAS Cure meeting. But those were the only two cases I know about of early treated individuals leading to post-treatment control. And I say post-treatment control because those individuals, both of those kids, have circulating infected cells. So it's not, it's very clear they're infected. There's DNA present, and there's inducible virus present in both of them. So there's some mechanism driving that. But really, do Fatima, if you know of cases that kids have really gone off treatment and have stayed suppressed. I mean, first do ARV testing to be sure, because we thought we had one case, and in fact, the child was still taking meds. So I would caution you to make sure you do some ARV testing. But it would be important for us to start collecting those data, and I don't know, maybe we could brainstorm about how to do that at a global level. I know and maybe Paolo wants to comment on this. I know the Italian group in EPICAL is considering an ATI study. I'll say in a 14-year-old that we studied who was treated and suppressed from 2 months of age, was antibody negative, and wanted to go off therapy in preparation for high school. It was very sobering. He rebounded. Actually, it was a patient of Georgetown. He rebounded in 2 weeks. And so if you know of cases that have maintained suppression beyond that period, would be helpful. And again, we had the one child at 24 weeks, but had other factors that suggest contributed to that longer duration of suppression. A long answer to a short question.
Fascinating. We have a question over here, number 1.
Hi, I just want to actually congratulate and make a comment to say that the CURE agenda has had not only scientific impact, but internationally. It's really helped move, excuse me, countries from really implementing early testing, engaging women to help improve early infant diagnosis, and identifying women who are lost in that cascade, who show up who don't know they're HIV infected or who were fallen off of treatment. And in Haiti, we're one of the sites where we did P1115. And just in the few years where we've been implementing the CURE agenda, it's really helped countries at the national level be more aggressive. So I want to congratulate you and really say that this is an important agenda because it has broader than scientific benefits. It also raises some important questions about how we lag behind in treatment for children.
Yeah.
I mean, we're still, as you mentioned, investigating very old ART regimens. And there's this, back to Martina, what was saying, we've been really good at pushing dolutegravir, but then countries are kind of left grappling with what else are they going to offer their children who fail or don't tolerate dolutegravir. So I just wanted to comment to say that the cure agenda has had greater than scientific advantages. It's really, really good to push countries forward.
Yeah, thank you, Vanessa, for saying that. And I often have a slide on that. I think it's pushed early diagnosis and treatment. But I don't think without a cure agenda, we would have moved beyond nevirapine for the neonatal period. And actually, the raltegravir protocol was started actually with Alvan to find, you know, we only had nevirapine, and we didn't even have PK dosing for nevirapine when we started this agenda. And the fact that we've gotten to the point where immunotherapeutics, I think, which is going to be key, immunotherapeutics are being studied. I mean, the fact that we can actually highlight number of blue box, you know, labels on those BNABs is what's most rewarding for me about this agenda. So we may not get to, I'm not going to say that, we want to get to remission, but we will have new ways of treating children, you know, with immunotherapeutics, which is where I think we're going to get the most out of. But thank you for making that comment.